Assalamu alaikum everyone. I am Dr. Mariam Tahir, International Registered Physiotherapist and Director of PMC Professionals Hub. I warmly welcome you all to our course named as PMC Certified Manual Lymphatic Drainage MLD 3-hour clinical workshop. Okay. So this is a focused 3-hour online clinical workshop designed to take you from basic concepts to clinical understanding of lymphatic drainage, basic to advanced. It's a short course of 3 hours, 1 day 3-hour short course of MLD, PMC certified manual lymphatic drainage. Okay, as this is an online session, we will be covering theoretical concepts, clinical reasoning, and technique understanding through demonstration based learning. Okay, practical hands on mastery requires physical training, which I will guide you about as well via video practical session. Okay, so lymphatic drainage is not just a technique, it's a clinical skill that plays a key role in post-surgical recovery. Okay, edema management. Firstly, key role is post-surgical recovery. Secondly, edema management. Thirdly, rehabilitation and even aesthetic practice. Okay, a strong understanding of this system can significantly improve your patient outcomes. Okay, so what would you be able to learn after this short course? What is your learning outcomes? By the end of the session, you will be able to understand lymphatic anatomy and physiology. Secondly, differentiate types of swelling. Okay, you can differentiate types of swelling as well. Okay, then thirdly, you can apply clinical reasoning, and fourthly, you will be able to understand the correct principles behind manual lymphatic drainage techniques. Okay, so we will move step by step from basic concepts to advanced clinical application. So stay attentive as each part builds on the previous one. Okay, you have to be listen attentively. Okay, because all topics should be interlinked with each other. Okay, so let's begin with the foundation, understanding what lymphatic drainage actually is and why it is clinically important. So, introduction to lymphatic drainage and its clinical importance. Okay, so what is lymphatic drainage? Lymphatic drainage refers to the physiological process by which excess interstitial fluid, proteins, metabolic waste, and toxins are collected and transported through the lymphatic system back into the venous circulation. Okay, it means that the body has a natural mechanism to collect and remove excess fluid, okay, that leaks out of blood vessels into the surrounding tissues, okay, along with proteins, metabolic waste products, and toxins, and then transport this material through a specialized network called the lymphatic system back into the bloodstream. It's called venous circulation. Okay, in simpler terms, you can say that when fluid leaves the blood capillaries to nourish tissues, not all of it returns directly. Okay, the remaining fluid along with larger molecules that cannot re-enter the blood vessels okay, is taken up by the lymphatic system. Okay, this fluid is called lymph. Okay, so the lymphatic system then acts like a drainage and filtration pathway. Okay, moving this fluid step by step through lymph vessels and lymph nodes. Okay, where harmful substances are filtered before eventually returning it to the venous system near the heart. Okay, so essentially lymphatic drainage is the body's way of firstly preventing fluid accumulation, that is swelling, secondly removing waste and toxins from tissues, okay, thirdly maintaining internal balance, that is homeostasis, fourth is supporting immune defense. Okay, these four ways are included. Okay, lymphatic drainage is the body's way of these four. Okay, swelling, homeostasis, and removing waste and toxins from tissues, and fourth is supporting immune defense. Okay, clinically, when this process is impaired, fluid starts accumulating in tissues. Okay, leading to conditions like edema or lymphedema. Okay, which is why understanding lymphatic drainage is crucial in patient management. Okay, I think you are now understood with the definition of what is lymphatic drainage. Okay, so in clinical practice this concept is operationalized as manual lymphatic drainage, MLD. Okay, a specialized, gentle and rhythmical therapeutic technique designed to stimulate lymph flow, firstly, secondly enhance removal of excess fluid, thirdly support immune and healing processes. Okay, unlike the cardiovascular system, the lymphatic system is a low pressure unidirectional system without a central pump. Okay, unlike the cardiovascular system, that is the lymphatic system is the low pressure. Okay, lymphatic system is a low pressure unlike the cardiovascular system. Okay, lymphatic system is a low pressure as well as unidirectional system without a central pump. Okay, flow depends on firstly intrinsic contraction of lymph vessels, that is lymphangions, secondly skeletal muscle activity, thirdly respiratory movements, fourthly external manual stimulation, that is MLD. Okay, so next is key functions of the lymphatic system. Okay, understanding lymphatic drainage requires clarity on the system's core roles. Okay, you should know the system core roles. Okay, what are the key functions? Firstly, fluid balance homeostasis is the key function. Here the points are, first key function of homeostasis is maintains equilibrium between capillary filtration and reabsorption. Secondly, returns excess interstitial fluid to circulation. Thirdly, prevents tissue swelling, is edema. Okay, prevents edema. Okay, these three are the functions of homeostasis, that is fluid balance. Okay, second key function of the lymphatic system is protein and waste removal. Okay, what are the functions of protein and waste removal? What it include? Removes large molecules. Okay, protein, cell and debris. Okay, these three molecules are included in large molecules, proteins, cell debris. Okay, these two molecules are included. Okay, remove large molecules that cannot re-enter blood capillaries. Okay, what are the large molecules? Large molecules are proteins and which are the large molecules? Proteins and cell debris are the large molecules. Okay, they remove them and that cannot enter blood capillaries again. Okay, secondly, prevents protein rich fluid accumulation which can lead to chronic inflammation. Okay, this is also a key function of lymphatic drainage system, that protein and waste removal. Okay, So, third key function is immune defense. It includes firstly lymph nodes act as a biological filters. Firstly, secondly, facilitate activation of lymphocytes, T cells and B cells. Thirdly, protect against pathogens and infections. Okay, immune defense may include these 3 points. Okay, so third is what happens when lymphatic drainage is impaired. So we will discuss about. So you should also know that adult chain of survival first of all. That when what happens when lymphatic drainage is impaired, rescuers should follow these steps. Capacity is reduced or overloaded. It leads to fluid accumulation and tissue changes. Okay, what happens when lymph transfer capacity becomes overloaded or reduced? It causes fluid accumulation and tissue changes. Okay, like edema, that is excess fluid in interstitial spaces. Okay, second is lymphedema, that is chronic protein rich swelling due to lymphatic dysfunction. Okay, fibrosis, that is long term tissue hardening. This is fibrosis. Okay, next is delayed healing, that is due to poor clearance of waste and inflammatory mediators. That is delayed healing. These impairments or changes may occur when lymph transfer capacity becomes overloaded or reduced. First is edema, second is lymphedema, third is fibrosis, fourth is delayed healing. Okay, common causes. What are the common causes of this? Common causes may include, first is surgical removal of lymph nodes, for example mastectomy. Okay, secondly trauma or injury, thirdly infection, fourthly tumors or obstruction, fifth is congenital abnormalities. These five are the common causes of lymphatic drainage impairment. Okay, so next is clinical importance of lymphatic drainage, why it matters. So why it matters? What are the clinical importance of lymphatic drainage? Why it matters? Edema management. Firstly, we will see out clinically edema management. Core application. Okay, MLD is widely used to firstly reduce post-operative swelling, secondly manage lymphedema, especially breast cancer related. Okay, thirdly control inflammatory edema after injury. Okay, this is edema management. They have to reduce post-operative swelling, secondly manage lymphedema, especially breast cancer related. Okay, thirdly control inflammatory edema after injury. Okay, second clinical importance of lymphatic drainage is post-surgical rehabilitation. Okay, firstly accelerates recovery by improving fluid clearance. Okay, secondly reduces pain and tissue tension. Okay, thirdly enhances scar healing. Okay, these three are the clinically related points for post-surgical rehabilitation. Third clinical importance of lymphatic drainage is pain reduction. Decreases pressure on nociceptors caused by swelling. First point is this. Second is promotes relaxation via parasympathetic stimulation. Okay, these are the points for pain reduction. Okay, so the fourth clinical importance of lymphatic drainage is improved circulation and healing. How? Facilitates nutrient exchange, firstly. Secondly, enhances removal of metabolic waste. Okay, thirdly supports tissue repair process. Okay, that's like they improve circulation and healing. Okay, fifth clinical importance of lymphatic drainage is clinical relevance for role in aesthetic and cosmetic practice. What are the role in aesthetic and cosmetic practice? They reduces facial puffiness. Okay, firstly. Secondly, improve skin appearance. Okay, they improve skin appearance. Okay, thirdly, commonly used for cosmetic procedures, for example liposuction. Okay, these are the clinical importance of lymphatic drainage. First is edema management, second is post-surgical rehabilitation, third is pain reduction, fourth is improved circulation and healing, fifth is role in aesthetic and cosmetic practice. Okay, so fifth topic is clinical relevance for physiotherapists. Our next topic is clinical relevance for physiotherapists. So, for physiotherapists, lymphatic drainage is not just a technique, it is a clinical reasoning skill. Okay, lymphatic drainage is a clinical reasoning skill for physiotherapists. Okay, firstly, they helps in differential diagnosis, edema versus lymphedema versus inflammation. Okay, it helps in differential diagnosis. Okay, secondly, guides treatment planning in rehab protocols. Okay, thirdly, integrates with exercise therapy, compression therapy and patient education. Okay, they integrates with exercise therapy, compression therapy and patient education. Okay, it is specially relevant to orthopedic rehab firstly, secondly oncology rehab, thirdly sports injuries, and fourth is neurological conditions with immobility. Okay, so lymphatic drainage is basically a clinical reasoning skill for physiotherapists. Okay, they help in differential diagnosis, guides treatment planning, integrates with exercise therapy, compression therapy, and patient education. And especially, it is relevant to orthopedic rehab, oncology rehab, sport injuries, and neurological conditions with immobility. Okay, so what are the key concepts to emphasize to students? To you all of the students. So the key concepts for lymphatic drainage is not deep massage. Okay, it is superficial. Firstly, secondly, slow and rhythmic. Thirdly, direction specific, like based on lymph pathways. Okay, incorrect technique, deep pressure can collapse lymph capillaries. Okay, if you don't know the exact technique, then incorrect technique or deep pressure, okay, will collapse lymph capillaries and worsen fluid stagnation. Okay, so you have to be the enough knowledge regarding how to do the lymphatic drainage. Okay, it's not a deep massage. Okay, it is superficial, slow and rhythmic and direction specific. Okay, based on lymph pathways. Okay, so incorrect technique or deep pressure can cause collapse lymph capillaries, worsen fluid stagnation. Okay, so our summary for this topic is lymphatic drainage is a vital physiological and therapeutic process that maintains fluid balance. Okay, that lymphatic drainage is a vital physiological and therapeutic process that maintains fluid balance. Okay, supports immunity. Okay, and facilitates healing. Okay, these three things that the lymphatic drainage maintains. Okay, its clinical application through MLD plays a crucial role in managing edema, enhancing recovery, and improving patient outcomes across multiple healthcare domains. Okay, so our first topic has completed. So let's move ahead to the second topic. Okay, now we will discuss about anatomy of the lymphatic system. Okay, so first is lymphatic vessels. Okay, firstly we will discuss regarding lymphatic vessels in anatomy of lymphatic system. Okay, Here is structural hierarchy. So what is the structural hierarchy of lymphatic vessels? So the lymphatic system is organized as a one-way drainage network, okay, beginning in peripheral tissues and terminating in the venous circulation, okay. It consists of progressively larger channels, okay. Firstly, lymphatic capillaries, that are initial vessels, okay. The structure is that of lymphatic capillaries is first blind-ended microscopic vessels located in interstitial spaces, okay. Lymphatic capillaries are blind-ended microscopic vessels located in interstitial spaces. Lymphatic capillaries are composed of a single layer of endothelial cells, okay. They are overlapping endothelial edges form mini valves, okay. They form mini valves. How they form mini valves? Overlapping endothelial edges, okay. And the anchoring filaments connect them to surrounding tissues, okay. They are anchoring filaments, okay, anchor points, that connect with each other, okay. Anchoring filaments, they are basically that connect them to surrounding tissues, okay. So what are the key features of lymphatic capillaries? So lymphatic capillaries are firstly highly permeable, more than blood capillaries, okay. Allow entry of interstitial fluid. Secondly, plasma proteins. Third is cellular debris. And fourth, pathogens, okay. They allow entry of these four things, okay. Interstitial fluid, plasma proteins, cellular debris, and pathogens, okay. So what are the functions of lymphatic capillaries? First point of lymph formation, okay. Lymphatic capillaries are first point of lymph formation, okay, and they absorb excess fluid that cannot re-enter venous capillaries, okay. So what is the clinical relevance? So easily collapse under pressure, okay. Lymphatic capillaries are easily collapse under pressure. Explains why MLD uses very light touch. They explains that why MLD uses very light touch, okay. So first we have discussed about lymphatic capillaries, that is initial vessels, okay. Secondly, they are pre-locators, okay. We will discuss about collectors, okay. Pre-collectors, they are basically transition zone between capillaries and collectors, okay. Transition zone between capillaries and collectors are pre-collectors, okay. The structure of pre-collectors is slightly larger than capillaries and they contain occasional valves, okay. They are slightly larger than capillaries and they contain occasional valves, okay. What is the function of pre-locators? They transport lymph from capillaries to collecting vessels, okay, and they begin directing flow toward regional lymph nodes, okay. They begin to directing flow toward regional lymph nodes, okay. So we are discussing basically structure hierarchy of lymphatic vessels. The first point in the first channel in lymphatic vessels structure hierarchy is lymphatic capillaries, initial vessels. Second channel is pre-collectors, and third we will discuss about collecting lymphatic vessels, okay. What is the structure of collecting lymphatic vessels? Thicker walls, they are thicker walls with smooth muscle, okay. They are thicker walls with smooth muscle, okay. They contain numerous bicuspid walls, give a beaded appearance, okay. They contain numerous bicuspid walls that give a beaded appearance, okay, like a beads, okay. And they divided into segments called lymphangiones. Okay, they divide into segments that are called lymphangiones. Okay, so what is lymphangione? Functional unit between two walls. The functional unit between two walls is known as lymphangione. Okay, has intrinsic contractility that acts like a mini pump. Okay, lymphangione has intrinsic contractility, like they acts like a mini pump. Okay, what is the function? Propel lymph flow. Okay, they propel lymph forward via rhythmic contraction and external forces like muscle movement and breathing. Okay, these are the functions. Okay, what is the clinical relevance? That proper direction of MLD follows these pathways. Okay, dysfunction leads to stagnation and edema. Okay, so the fourth step or channel in structure hierarchy of lymphatic vessels is lymphatic trunks and ducts. Advanced overview will give you here that major trunks are jugular, subclavian, bronchomediastinal, lumbar and intestinal. Okay, these five are major trunks in lymphatic trunks and ducts. Major trunks are jugular, subclavian, bronchomediastinal, lumbar and intestinal. These five are major trunks, and major ducts are thoracic duct and right lymphatic duct. Thoracic duct drains approximately 75% of body. Okay, empties into left subclavian vein. Okay, and the right lymphatic duct drains right upper quadrant and right subclavian vein. Okay, right upper quadrant to right subclavian vein. Okay, there is right subclavian vein in right upper quadrant. Okay, so next we will discuss about lymph nodes, structure and function. So let me tell you before we start next topic that lymphatic vessels structure hierarchy includes 4 levels. Okay, 4 channels. The first is lymphatic capillaries, that is initial vessels. Second is pre-collectors, that is transition zone between capillaries and collectors. Third is collecting lymphatic vessels. Here we will discuss about lymphangione, that is a functional unit between two walls. Okay. Fourth is lymphatic trunks and ducts. We have discussed here major trunks and major ducts, that is 5 major trunks and 2 major ducts. Okay, so next we will discuss about lymph nodes, structure and function. Okay, lymph nodes are small bean shaped filtering organs located along lymphatic pathways. Okay, so the structure of lymph nodes is enclosed by a fibrous capsule. Okay, lymph nodes are enclosed by a fibrous capsule. They are divided into cortex, B cell region. Cortex is a B cell region, and paracortex, that is T cell region, and medulla. Lymph nodes are divided into 3 parts. Okay, cortex, paracortex and medulla. Cortex is B cell region, paracortex is T cell region, and medulla. Okay, and 2 vessels, that is afferent vessels and efferent vessels. Started with A and started with E. Afferents from A bring lymph into node. Okay, efferent started with E carry filtered lymph out. Okay, afferent bring lymph into the node and efferent carry filtered lymph out. Okay, what is the function of lymph nodes? Firstly, the function of lymph node is filter lymph. Okay, like they remove pathogens and debris. Okay, Secondly, they activate immune response, okay? Thirdly, they produce lymphocytes. These are the three functions of lymph nodes, okay? So our next topic is major lymph node groups. Clinically important. This is very clinically important, okay? That major lymph nodes group. Understanding these groups is critical for MLD direction and drainage planning, okay? So firstly, we will discuss about head and neck nodes, okay? Cervical nodes, superficial and deep, okay? Submandibular, submental and occipital. These three are cervical nodes that are superficial and deep, okay? So the drainage area for cervical nodes are scalp, face, oral cavity and neck. 4 areas are here for drainage for head and neck nodes: scalp, face, oral cavity and neck, okay? So what's the clinical use here? First is facial edema, okay? Second is sinus related swelling, we can treat, okay? And the post cosmetic procedures, okay? These three are clinically cases, you can say, okay? Clinical use, okay? So next we will discuss about upper limb and thoracic nodes, okay? Auxiliary lymph nodes are most important, divided into 5 parts, that is anterior, that is pectoral, posterior, that is subscapular, lateral, that is humeral, and central and apical. These 5 divisions are of auxiliary lymph nodes, okay? So the drainage area of auxiliary lymph nodes are upper limb, breast and thoracic wall. These 3 areas are drainage of auxiliary lymph nodes, okay? So the clinical relevance for auxiliary lymph nodes: key in post mastectomy lymphedema, okay? Post mastectomy lymphedema and primary drainage basin in upper limb MLD, okay? Primary drainage basin in upper limb MLD, okay? So next we will discuss about lower lymph nodes. Lower lymph nodes. Lower lymph nodes are inguinal lymph nodes, okay? They are superficial inguinal lymph nodes and deep inguinal lymph nodes. So the drainage area for inguinal lymph nodes are lower limb, we can drainage through lower limb area, external genitalia and lower abdominal wall, okay? So the clinical relevance is used in lower limb edema management, okay? You can use this in clinical relevance like used in lower limb edema management, and this is essential for ankle or knee swelling drainage, okay? So abdominal abdominal nodes, okay? Abdominal nodes, okay? That is mesenteric nodes and para-aortic lumbar nodes, okay? These two are abdominal nodes, mesenteric and para-aortic lumbar nodes, okay? So the drainage area for abdominal nodes are gastrointestinal organs and abdominal viscera. These two are drainage area of abdominal nodes, okay? So thoracic nodes are 2, that are mediastinal nodes and bronchopulmonary nodes. So the drainage area for thoracic nodes are lungs and thoracic cavity. You should know about the nodes placement, where they are present and what are the drainage area for that, and what could be the clinical relevance or clinical use of these nodes, okay? So next we will discuss about direction of lymph flow, like key clinical concept. Lymph always flows from peripheral tissues to capillaries to collectors to lymph nodes to trunks to ducts to venous system, okay? This is a flow chart for direction of lymph flow, okay? So MLD must always follow anatomical pathways, okay? You should follow anatomical pathways, that how you should release the lymph nodes, okay? Clear proximal areas first. For example, axilla before arm. Okay, you have to clear proximal area first. For example, axilla before arm. You have to follow anatomical pathways. Okay. So, clinical integration regarding this topic. Firstly, lymphatic system is superficial and delicate. Okay. Secondly, nodes act as checkpoints. Okay. Thirdly, drainage is region specific and directional. Okay, you should follow the anatomical pathway. Okay, you should follow the anatomical sequence. Okay. So what are their common mistakes? Applying random massage without understanding node locations, ineffective or harmful. Okay, if you apply random massage but you don't know what is the exact location of nodes, then it could be ineffective and most probably it would be harmful for the patient. Okay, so make sure you are following the anatomical position, anatomical pathway, anatomical sequence. Okay, so summary regarding this topic is that the lymphatic system is a highly specialized low pressure drainage network composed of capillaries, vessels and nodes that work together to maintain fluid balance, okay, remove waste and support immune function. Okay, a precise understanding of its anatomy is essential for safe and effective application of manual lymphatic drainage, MLD. Okay, so next we will discuss about physiology of the lymphatic system. Okay, so physiology of the lymphatic system. First we will look out lymph formation, that how lymph form. Okay, the first point regarding lymph formation is capillary fluid exchange. It's a foundation term, foundation point, okay, of lymph formation, that is capillary fluid exchange. Firstly, capillary fluid exchange. Okay, at this level of blood capillaries, fluid movement is governed by Starling force. Okay, firstly, hydrostatic pressure, PC, okay, pushes fluid out of capillaries into interstitial spaces. Okay, secondly, oncotic pressure pulls fluid back into the capillaries due to plasma proteins. Okay, these are Starling force, hydrostatic pressure and oncotic pressure. Okay, hydrostatic pressure function is pushes fluid out of capillaries into interstitial space. Okay, and oncotic pressure always pulls fluid back into the capillaries due to plasma proteins. Okay, so not all filtered fluid is reabsorbed. Approximately 90% returns via venous capillaries and 10%, approximately 10%, like 2 to 4 liters per day, remains in interstitial space, becomes lymph. Okay, so second point for lymph formation is entry into lymphatic capillaries. Okay, entry into lymphatic capillaries. Here, excess interstitial fluid enters lymphatic capillaries due to overlapping endothelial cells acting as one-way microvalves. How they enter into lymphatic capillaries? The excess interstitial fluid enters lymphatic capillaries due to, what is the reason? Due to overlapping endothelial cells that acting as one-way microvalves. Okay, second reason is pressure gradient. When interstitial pressure rises, flaps open and fluid enters. Okay, so what are the contents of lymph? Water, plasma proteins, lipids, especially from intestines, chyli. Okay, intestine, that is chyli, chyle, chyli. Okay, fourth is cellular waste. Fifth is immune cells like lymphocytes. Okay, these 5 are content of lymph. First is water, second is plasma proteins, third is lipid, fourth is cellular waste, and fifth is lymphocytes, that is immune cells. Okay, So the key concept you should know, lymph formation is passive, driven by pressure differences, not active pumping. Okay. So next we will discuss about normal versus impaired lymphatic function. Okay. Understanding this distinction is central to clinical reasoning in edema management and appropriate use of MLD. Okay, you should be understand about normal versus impaired lymphatic function. Okay, firstly we will discuss about normal lymphatic function. So, functional overview of normal lymphatic function. In a healthy state, the lymphatic system maintains a dynamic equilibrium between interstitial fluid formation from capillary filtration. Okay. Secondly, lymphatic drainage capacity. Okay. This ensures no visible swelling and optimal tissue health. Okay. Second, we will discuss about key physiological characteristics. Okay. Here, first point is efficient fluid clearance. Firstly, excess interstitial fluid, approximately 2 to 4 liters per day, is continuously removed. Secondly, prevents accumulation in tissues. Okay, this happens in efficient fluid clearance. That is how efficient fluid clearance happens. Okay. Secondly, second point is intact lymphatic vessels. Here, the first point is capillaries readily absorb fluid due to high permeability. Secondly, collectors actively pump lymph via lymphangions. Okay. So the third key point for physiological characteristics is functional walls. Here, firstly, ensure unidirectional flow. Secondly, prevent reflux and stagnation. Okay. Fourth key physiological characteristic is adequate transport capacity. Here, lymphatic system can increase flow up to approximately 10 times. Okay, during stress. For example, exercise can be a stress. Okay, mild inflammation can be a stress. Okay. So fifth physiological characteristic is normal protein balance. Here, plasma proteins are effectively cleared from interstitium. Secondly, maintains oncotic pressure equilibrium. Okay, these 5 are the key physiological characteristics. Okay, next we will discuss about clinical presentation. Normal clinical presentation. Okay, there is no swelling. Secondly, soft, pliable tissues. Third is normal skin texture. Fourthly, rapid recovery from minor inflammation. Okay, these 4 are the clinical presentation for normal. Okay, next is we have discussed about normal lymphatic function. Now we will discuss about impaired lymphatic function. It occurs when lymphatic load is greater than transport capacity. Okay, load is higher than transport capacity. Okay, this results in fluid and protein accumulation in interstitial spaces. Okay, so what are the types of lymphatic failure? First type is mechanical insufficiency, that is low capacity. Okay, transport capacity is reduced. Okay, what is the reason? Causes is firstly lymph node removal, for example mastectomy. Secondly, radiation therapy. Third is tumor obstruction. Fourth is congenital malformation. These 4 are the causes that leads to lymphedema. Okay. So second type of lymphatic failure is dynamic insufficiency, like high load. Okay, your system is not but overloaded. Okay, dynamic insufficiency means that high load. Okay, that system is not normal but overloaded. Okay, what are the causes of this dynamic insufficiency? Firstly, acute inflammation can cause dynamic insufficiency, and secondly, trauma. Thirdly, infection. These 3 are the causes of dynamic insufficiency that leads to inflammatory edema. Okay. Third lymphatic failure type is combined insufficiency. both reduced capacity and increased load. Okay, both capacity reduced as well as load increases, both happens in combined insufficiency. Okay, this is more severe and chronic condition. Okay, these are the three types of lymphatic failure. First is mechanical insufficiency, that is low capacity. Second is dynamic insufficiency, that is high load. And combined insufficiency, here both capacity and load is reduced, capacity reduced and load increase. Okay, that is more severe chronic condition. Okay, so next we discuss about pathophysiology changes. Okay, first is fluid accumulation. Here excess interstitial fluid shows visible swelling. Okay, excess interstitial fluid causes visible swelling in fluid accumulation. Okay, second physiological changes is protein accumulation. Here high protein edema, unlike venous edema. Okay, high protein edema firstly. Second is attracts more fluid, causes worsening condition. Okay, more fluid attracts, cause worsening in condition. Okay, third pathophysiological changes are chronic inflammation. Here first chronic inflammation may include persistent immune activation. Secondly, tissue damage over time. Okay, fourth pathophysiological changes is fibrosis. Here hardening and thickening of tissues occurs and reduced elasticity. Okay, fifth changes is adipose deposition, that is late stage. Pathophysiological changes, here adipose deposition is a fifth pathophysiological change and this is a late stage. Okay, here fat accumulation in chronic lymphedema. Okay, fat accumulation in chronic lymphedema. Okay, so next we will discuss about, these are the 5 basically pathophysiological changes. Next we will discuss about stages of lymphatic impairment, clinical progression. Okay, stage 0 is latent, no visible swelling and transport already compromised. Okay, stage 1 is reversible. Here soft pitting edema and reduces with elevation. Okay, second stage is spontaneously irreversible. Here is non-pitting edema. Secondly, fibrosis begins. Thirdly, does not fully reduce. Okay, stage 3 is severe elephantiasis. Okay, stage 3 could be severe and or elephantiasis stage. Okay, firstly massive swelling. Secondly, skin changes, thickened and rough. Okay, thirdly, functional impairment. Okay, these are the 3 stages of lymphatic impairment regarding clinical progression. Okay, next we will discuss about clinical features of impaired function. First clinical feature is persistent swelling. Second is heaviness or tightness. Third is reduced range of motion. Fourth is skin changes like dryness and thickening. Fifth is increased infection risk, like increased infection risk, maybe cellulitis. Okay, clinical feature is cellulitis. Okay, fifth clinical feature of impaired function is cellulitis. Okay, so next we will look out key differences. So first feature is fluid balance. So the normal function of fluid balance is maintained. In fluid balance, normal function maintained and impaired function disrupted. Okay, normal function feature fluid balance maintained and impaired function fluid balance is disrupted. Okay, in normal function lymph flow is efficient and in impaired function lymph node is reduced or obstructed. Okay, in normal function tissue state is soft and healthy, but in impaired function tissue state is swollen and fibrotic. Okay, in normal function protein clearance is effective and in impaired function protein clearance is accumulation. Okay, in normal function immune function is balanced, and in impaired function, immune function is compromised or overactive. Okay, and this clinical signs for normal function is no edema, but in impaired function there is edema or lymphedema. Okay, so the clinical elements for practice, you should know that why this matters MLD. The question arises, yes, it is a positive point that if anybody is asked about it, why this matters in MLD. So firstly, determines treatment approach. Okay, to determine this matters is necessary in MLD because it determines treatment approach. Secondly, guides pressure, direction and sequence. Thirdly, helps differentiate lymphedema requires MLD. Okay, to differentiate lymphedema requires MLD. Okay, other lymphedema types may need different management. Okay, so these are the reasons that MLD matters. Okay, so important point is lymphedema is chronic and progressive if untreated. Okay, early intervention, then you have better outcomes. Okay, so what are the key points regarding this topic? Not all edema is equal to lymphatic problem. Okay, first is this key point. Second is lymphedema is protein rich and progressive. Third is early stage is reversible, but late stage is not. You should know that. You should treat lymphedema in early stage. Okay, don't take it risk. Okay, start your treatment in acute stage. Okay, so summary regarding this topic: normal lymphatic function maintains fluid and protein balance through efficient drainage and transport. Okay, impairment occurs when the system is overloaded or damaged. Okay, leading to fluid accumulation, inflammation and progressive tissue changes. Okay, clinically presenting as edema or lymphedema. Okay, now next we will discuss about key terminology in lymphatic disorders. Okay, so we will discuss here the key terminology in lymphatic disorders. First we will discuss about edema versus lymphedema. Okay, edema is a general term. Okay, what is the definition of edema? Edema is the abnormal accumulation of fluid in the interstitial space. Okay, regardless of cause. Okay, what is the pathophysiology of edema? Edema develops due to imbalance in Starling forces or fluid handling. Okay, firstly, increase capillary hydrostatic pressure. For example, heart failure. Okay, may cause heart failure. Okay, if capillary hydrostatic pressure increases, it cause heart failure. Okay, secondly, decrease plasma oncotic pressure may cause hypoalbuminemia. Okay, thirdly, increase capillary permeability can cause inflammation. Okay, and decrease lymphatic drainage may cause overload or obstruction. Okay, what are the types of edema? There are 4 types of edema. Okay, inflammatory edema, that may be caused by injury or infection. Second is venous edema, that may be caused by chronic venous insufficiency. Third is cardiac edema. Fourth is renal edema. Okay, so what are the clinical characteristics? Usually pitting edema. Pitting edema, indentation remains on pressure. What is pitting edema? Indentation remains on pressure. Okay, first characteristic is clinical characteristic is pitting edema. Second is often symmetrical, especially systematic causes. Okay, third is skin is soft and compressible. Fourth is improves with elevation in many cases. Okay, improves with elevation in many cases. These are the 4 clinical characteristics of edema. Okay, what is the key point of edema that you have to know? Edema is a symptom, not a diagnosis. Okay, edema is a symptom. Again I am revising, I am speaking that edema is a symptom, not a diagnosis. Okay. So second, we will discuss about lymphedema. Is a specific condition. Edema is a general term. Okay. Lymphedema is a specific condition. Okay. What is the definition of lymphedema? Lymphedema is a chronic progressive condition caused by impaired lymphatic transport leading to accumulation of protein-rich fluid in tissues. Okay. What is the pathophysiology of lymphedema? Firstly, reduced lymphatic transport capacity. Secondly, accumulation of proteins attracts more fluid. Okay. Protein accumulation attracts more fluids. Thirdly, chronic inflammation causes fibrosis and tissue changes. Okay. These three are the pathophysiology of lymphedema. Okay. What are the clinical characteristics of lymphedema? Firstly, initially pitting, later becomes non-pitting. Okay. Initially pitting, later becomes non-pitting. Second is often unilateral, especially secondary cases. Okay. Third is skin changes like thickening, fibrosis and hyperkeratosis. These are late stages. Okay. Hyperkeratosis are late stages. Okay. Skin changes may be thickening, firstly, secondly fibrosis, thirdly is hyperkeratosis. Hyperkeratosis is a late stage. Okay. And the fourth clinical characteristic of lymphedema is stemmer sign positive, means inability to pinch skin at base of toe or finger. Okay. This is a stemmer sign positive, that you can't pinch the skin at the base of toe or finger. Okay. And the fifth clinical characteristic of lymphedema is does not fully resolve with elevation. Okay. Progression. There are 0 to 3 stages of progression of lymphedema. Stage 0 is latent. Stage 1 is reversible. Stage 2 is fibrotic. Stage 3 is severe. It could be elephantiasis. Okay. What is the key point you should know in the lymphedema? Lymphedema is a disease entity, not just swelling. Okay. Edema is a symptom, not diagnosis, and the lymphedema is a disease entity, not just swelling. Okay. Edema is general term, but the lymphedema is a specific condition. So what are the core differences between edema and lymphedema? Nature. Features. We will discuss about features, how features are different between edema and lymphedema. Okay. Nature of edema is symptom and the nature of lymphedema is chronic disease. Okay. Fluid type of edema's fluid type is low protein usually, and the lymphedema fluid type is high protein. Okay. Edema causes are multiple systematic or local factors, and lymphedema causes are lymphatic failure. Okay. Edema pitting is common and lymphedema pitting is early only. Okay. Edema symmetry is often bilateral. Lymphedema symmetry is often unilateral. Okay. Edema skin changes are minimal. Lymphedema skin changes are progressive fibrosis. Okay. Edema response to elevation is improves day by day. Okay. But lymphedema response to elevation is limited. Okay. So next we will discuss about primary versus secondary lymphedema. Okay. So primary lymphedema, what is the definition of primary lymphedema? Lymphedema caused by congenital or developmental abnormalities of the lymphatic system is known as primary lymphedema. What is the pathophysiology of primary lymphedema? Firstly, hypoplasia. Secondly, aplasia. Third is hyperplasia. What is hypoplasia? Hypoplasia means underdeveloped vessels. Okay. What is aplasia? Aplasia is absence of vessels. Wherever you found A at starting, it will be absence of anything. Okay. Aplasia means absence of vessels. Okay. Hyper means increased, malformed but inefficient vessels. Okay. It's a latent condition. Okay. Hypoplasia is underdeveloped vessels in low case. Okay. can be treatable. Okay, these are the three pathophysiology of lymphedema, primary lymphedema. Okay, classification by onset. Firstly, congenital at birth, present at birth or within 2 years. This is congenital at. Okay. Secondly, lymphedema parox is the most common, appears during puberty or early adulthood. Okay. Third is lymphedema tarda. It appears after age 35. These are three classification by onset for primary lymphedema. Okay. So clinical features for primary lymphedema are: firstly, often affects lower limbs. Secondly, maybe bilateral. Thirdly, slow progression. Fourth is no clear external cause. Okay, these are the clinical features. Okay, examples of primary lymphedema is myeloid. Is a myeloid disease. Okay, is a myeloid disease that is congenital form. Okay, myeloid disease is a congenital form, is an example of primary lymphedema. Okay, so next we will discuss about secondary lymphedema. What is the definition of secondary lymphedema? Secondary lymphedema caused by damage or obstruction of a previously normal lymphatic system. Okay, common causes may include: first is surgical, lymph node dissection, for example breast cancer surgery. Okay, second common cause is radiation therapy like fibrosis and vessel damage. Okay, third common cause is infection like filariasis, common globally. Okay, fourth cause is trauma, here injury to lymphatic vessels. Okay, fifth common cause of secondary lymphedema is malignancies, that is tumor obstruction. Okay, what are the clinical features of secondary lymphedema? Post mastectomy lymphedema. Okay, involving upper limb after axillary node removal. Okay, these are the key clinical examples of secondary lymphedema, that post mastectomy lymphedema involving upper limb after axillary node removal. Okay, and what are the clinical features? First, unilateral. Secondly, onset linked to identifiable event. Thirdly, more localized, for example arm after mastectomy. Okay, so primary versus secondary lymphedema. So we should do the comparison of these. You may understand better about primary and secondary lymphedema. Okay, so primary lymphedema causes congenital and developmental, but secondary is acquired damage. Okay, onset of primary lymphedema is gradual and age related, and secondary lymphedema onset is after event like surgery or trauma. Okay, distribution of primary lymphedema is often bilateral. Distribution of secondary lymphedema is usually unilateral. Okay, predictability of primary lymphedema is less predictable, and secondary lymphedema is clinically traceable. Okay, primary lymphedema common area is lower limbs, and the common area for secondary lymphedema is upper limb post surgery. Okay, so what are the clinical importance of these terms? Why differentiation matters? You should know. The question should be raised at why differentiation matters. So firstly, guides treatment planning. Secondly, determines prognosis. Thirdly, helps in patient education. Fourth is influences use of MLD and compression therapy and rehabilitation protocols. Okay, these are the clinical importance that why differentiation matters. Okay, so critical insight for practice. What are the critical insight for practice? Not all edema should be treated with MLD. Okay, secondly, correct diagnosis prevents ineffective or harmful treatment. Okay, you should know the exact anatomical sequence so you can do the correct diagnosis, so the person, the sufferer can have effective treatment, not harmful treatment. Okay, so what is the summary regarding this topic? Edema is a general term for fluid accumulation, whereas lymphedema is a chronic condition resulting from lymphatic dysfunction. Okay, lymphedema can be primary due to developmental abnormalities or secondary due to acquired damage. Okay, and accurate differentiation is essential for effective clinical management. Okay.